I wanted to first welcome you all to this webinar on the 670G system. It's a pleasure to be speaking to you all, and today I'm excited to share about how to onboard patients onto the 670G system. So we're really getting into kind of the practical approach to getting a person onto the 670G system and then titrating them successfully. So this is kind of a laundry list of things, if you will, in regards to the safety information. Some of the key take-home messages are that this system should be used in patients with type 1 diabetes, that patients should use their finger sticks in order to confirm what their glucose value is and to give meal boluses and correction boluses. And then also there is this warning that the system should not be used in patients below the age of 7. And the reason for that is because these patients were actually not studied on the 670G system. Also, in the pivotal trials, there was an exclusion criteria for patients who were less than 8 units per total daily dose of insulin. And here are some additional warnings as well. And as a reminder, the topics of this conversation are on-label only. However, there is a website on the slide provided for off-label questions should you have them. So one of the continuing challenges in patients with type 1 diabetes is that management can be complicated. Patients are having to try to adjust their insulin by their glucose. They're trying to do carbohydrate counting. And as I like to say, carbohydrate counting can be very unforgiving. And so you have this sort of complicated management, and that many patients say is actually mentally demanding as well. And you put those two things together, and it often results in patients not reaching goals and also impacting the quality of their life. So in order to better understand how the 670G system is really addressing the complexity of the management of type 1 diabetes, let's turn now to the nighttime. Now, the way I describe the management of auto mode during the night, it's kind of like an autopilot, or at least this is the way I describe it to patients. When the patient goes to bed at night, the system essentially takes over their insulin delivery. We often talk about inter-subject variability, where the total daily dose changes between subjects. But what we've learned from closed loop is that there's an extreme amount of intra-patient variability. So when you look at night, in order to maintain a glucose that is within a reasonable level or within target range, you see a significant variability in the insulin delivery that is very dynamic, very similar to the beta cells of the pancreas. On one night, if you look at the right lower hand quadrant, you see a suspension of insulin delivery. While on other nights, when you look at the left upper quadrant, you see both a suspension and also an increase in insulin delivery and then decrease all throughout the night in order to maintain a relatively flat glucose. So now looking at the day, I like to describe the auto mode more like a co-pilot. So the patient is bolusing, giving correction insulin, and then the system is automating around based on their individual sensor glucose readings and the prediction of those sensor glucose readings, how much insulin to give to keep that patient's blood sugar within target. When you look to the left of the slide, you can see tremendous glycemic variability within manual mode, not uncommon for our patients with type 1 diabetes. And in this case, during the first few days, you see a significant reduction in that glycemic variability, a lot less lows, a lot less highs as that patient transitions into auto mode. This next slide is looking not only at the nighttime, but also during the day. And so during the day here in manual mode, while the patient is not in closed loop, you can see significant variation, blood sugars going as high as 400 and then coming down close to 50. And then when the patient goes on to closed loop for the first time, this is a real success story where the glycemic variability immediately or within the first few days significantly decreases. Now we know that this isn't the case in all of our patients, and so that's kind of the purpose of this webinar, if you will, to go over how to adjust patients to optimize the 670G system and try to decrease variability as much as possible. So what are the challenges of diabetes management that the 670G is trying to address? If you were to break it down into 3 areas, the first is better glucose control with automation. So in the pivotal trial, we saw patients had an average A1C of less than 7%, but more importantly, they also had an increased time in range, less hypoglycemia as evidenced by the sensor glucose readings, and also less hyperglycemia as well. Also, when you looked at the safety data in the pivotal trial over 3 months, there was no severe hypoglycemia or DKA. So the last key area that the 670G really helps to address in the challenge of managing diabetes is an area that I like to call the new normal. Patients, as I had mentioned earlier, expressed that managing type 1 diabetes can be very complicated, and there can be a lot of guilt associated with their blood sugars, whether they go too high or too low. Having a form of automation that individualizes insulin delivery based on that sensor glucose and suspends insulin or gives more or less insulin based on that sensor glucose and the prediction of where that sensor glucose is going. For many patients, they actually say that it helps to significantly reduce that burden for many patients, they tell us that it helps to significantly reduce that cognitive burden that they live with day to day by knowing that the 670G is automating their management. The other thing that I found interesting within my own practice is that new conversations are now arising. So because I only have to focus on the insulin-carb ratio and the active insulin time, and I'm no longer spending time on trying to figure out what their exact basal rate should be, or if they should have differing basal profiles, one profile for this type of situation, another profile for this situation, I'm actually able to focus on the patient themselves. It really opens up a lot of new dialogue with the patient, how they're doing in terms of compliance, how they're doing overall with their diabetes, how they're managing things like their diet and exercise. So how do the real-world results compare to the 670G trial? Well, when we've looked at over 3,000 patients in the initial launch of the study, when you look at the real-world data across different areas of sensor glucose distribution, so time in range, time below 50, time below 70, time above 180, what you'll see is that the real-world data is actually very comparable to the pivotal trial data. In fact, in the pivotal trial data, there was approximately 12,000 patient days. In the real world data, there's almost 10 times that amount. So there's over 100,000 device patient days that we looked at. So when you looked at time in target with the real world data, approximately 73%, very similar to the pivotal trial, had time in range. In the pivotal trial, it was 72.2%. Similarly, the time in auto mode was very similar as well. It was 85% in the real world data and 87% in the pivotal trial. The sensor wear was also comparable at 95% in the real world data and also the pivotal trial data as well. For time below 70, in the real world data, it was around 0.4%. Time below 50, and in the pivotal trial, 0.6%. For time below 70 in the real world data, 2.35%, and in the pivotal trial, 3.3%. So actually in the lower range, the real world data was trending even lower than the pivotal trial. Time above was 24%, in the time above 180 in the real world data was 24%, and in the pivotal trial was also 24%. And then time above 300 was very similar in both the real world and pivotal trial data. Similarly, the mean sensor glucose was also very similar in the real world data and the pivotal trial data as well. what are some of those key insights that they can provide? The first is that over 90% felt that the system met or exceeded their expectations for improving A1C. And 4 out of 5% actually felt that it improved their time in range, and over 90% felt that it improved their overall health. The majority also felt much more confident, in fact over 90%, in their ability to manage their diabetes. 86% felt that it gave them greater peace of mind, and 4 out of 5 patients felt that it helped to reduce the day-to-day effort of managing their diabetes. In regards to the system, the majority of patients, 72%, felt that the accuracy of the Guardian Sensor 3 was as good. In regards to the feedback of their trust in the sensor, their feedback was quite positive. 72% felt that the accuracy of the Guardian Sensor 3 was very good to excellent, and 89% felt that they trusted the MiniMed 670G system to help manage their glucose levels. 90% said that their experience of using the 670G met or exceeded their actual expectations. So let's move now to the case study, because I think case studies are the best way that we as providers learn how to manage our patients. So in this case, it's an actual case. Her name isn't Holly to protect her privacy. It's a 34-year-old patient with type 1 diabetes for 13 years. And we're using this case to illustrate the transition from manual mode to auto mode. She fears having high blood sugars, and she prefers to have her blood sugars around 80 to 90. So very typical of these patients, they can run very high basal rates. And even though she's trying to avoid carbohydrate intake, she actually carries juice boxes everywhere she goes. Now her A1C has actually changed. Before it was 5.8%, and it moved up from that to 6.3%. I suspect that she actually was having a lot of lows in the 5.8% range. So let's look and see how her overall glucose is doing. When you look at her goals are to maintain glucose control and also lose weight as well. So I wanted to share with you a methodology called AIM. I think a lot of us within the healthcare practice are already using a similar methodology. So A stands for assess, I for identify and confirm, and M for making changes, or kind of the management plan. In regards to assess, we're looking at the overall glycemia, time in auto mode, sensor wear, average sensor glucose. In terms of identify and confirm, we're really trying to identify what are those problem areas that the patient may have that you can make a therapy adjustment. And the last thing would be obviously making changes, adjusting their insulin carbohydrate ratio, potentially adjusting their active insulin time as well. So in this next slide, when you're trying to assess the overall glycemic control, if you look at manual mode, the first thing you'll notice is that the sensor glucose readings are in fact going below 70, and in some cases are actually going below 50. Now if you look at the auto mode CareLink report, what you'll notice is that the sensor glucose readings now are no longer going below 70, and in fact the patient has no sensor glucose readings of 50 milligrams per deciliter or below. The other thing that you'll notice too is that there's a lot less variability. So if you notice that the wideness of the graph actually shrinks when the patient goes from manual mode to auto mode. In fact, it's a very small variability in the early morning hours of the day and significantly less variability into the afternoon and the evening than the patient had in manual mode. And this is actually one of my favorite graphs, if you will, on CareLink report. And you can see in manual mode, the patient had about 4% of hypoglycemia, that is blood sugars less than 70. And then in auto mode, you can see the patient had an elimination of all of their hypoglycemia altogether. Now, there's an important point on this slide. If you look, low glucose, 50 to 70 milligrams per deciliter less than or equal to 3%. That is now the recommendation when you're looking at these time and ranges or these graphs to make sure that you have a patient whose blood sugar or sensor glucose between 50 to 70% is less than 3%. And certainly if you have a patient whose blood sugar is less than 50 milligrams per deciliter, it should in fact be less than 1%. In fact, in my own practice, I try to have that as minimal, if no blood sugars less than 50. The patient's time in range decreased very slightly by about 3%. And so I think that's part of the ongoing adjustment. So if you notice on the graph, there is a slight decrease in the time in range of about 3%, going from 86 to 83%. But I will say this, time in range of 83% is actually quite good. And when you think about the goals or the recommendations for time in range, it will be recommended to be above 70% within that time in range period. So how is this patient doing in terms of their pump settings? When you look at their auto mode settings, really what you're targeting is a sensor wear of above 85%. And so this patient's sensor wear is at 97%. You're also targeting auto mode to be above 80%. And in this case, the patient's auto mode is at 94%. When you look at manual mode and you look at their basal rate, 73% of their total daily dose of insulin was actually given in basal. And that is, as we know, much too high. Their bolus ratio was about 27% of their total daily dose. Then when they went into auto mode, they had a much better basal bolus distribution. So you see that their basal rate was at 59% for auto basal and then 41% for the bolus amount. Another helpful report is in front of you within CareLink. And what this report does is it overlays the sensor glucose readings with the blood glucose and then also the insulin delivery. What you'll note, what's most easily recognized on this report are the very high postprandial blood sugars. So if you look at dinner on Thursday, you'll see a very high postprandial blood sugar after dinner. If you look on lunch on Friday the next day, you'll see a high postprandial lunch as well as a high postprandial dinner. And so if we're to identify the cause, one of the causes then of this patient's struggle with hyperglycemia has to do with insufficient bolus amounts of insulin during the meal. Her current settings are a carb ratio at 12 a.m. of 8 and an 11:30 a.m. of 7, and her active insulin time is at 2.5 hours. So in this case, the patient appropriately intensified the bolus settings. The carb ratio at 12 a.m. went down to 7. At 11:30 a.m. it was changed to 6.5, and at 5 p.m. it was changed to 6. Also, the active insulin time decreased from 2.5 hours down to 2 hours. Now, clinically, it was very interesting that Holly had lost 2 pounds in the first 2 weeks in auto mode, and she hadn't replenished her juice box stash. I think for many of our patients with type 1 diabetes, they try to eat to catch up with their insulin. And in this case, because auto mode was allowing for the suspension of insulin delivery and a decrease, Holly was not having so much hypoglycemia that she was having to take carbohydrate to try to avoid or treat her hypoglycemia. So in this case, where Holly was having significantly less hypoglycemia, she wasn't having to treat that hypoglycemia with this juice dash or try to prevent it with a juice dash. Instead, she could allow the automated system to address and mitigate her hypoglycemia. So what then happened to her overall glucose control? When you compare the auto mode in week 1 compared to the auto mode in week 3, so what happened after those adjustments? When you compare week 1 to week 3, what you'll notice is that she had significantly less postprandial variation. So she's not swinging up as high as she did in week 1. And in auto mode in week 3, you see less hyperglycemia all throughout the day. If you then look at her sensor glucose distribution, what you'll see is that she went from 83%, and remember it had slightly decreased her time in range. That time in range went from 83% all the way up to 92%. That is quite remarkable. Now, what is important is, did this cause an increase in hypoglycemia? Actually, when you look at her sensor glucose distribution, only 1% was in that 50 to 70 range. So that target, again, if you can look at the graph at the top, is less than 3%. So the fact that she had 1% was not a significant increase in hypoglycemia. And actually, I would be very comfortable with her settings. Now, if that had gone from, let's say, 1%, let's say it was 4% for 50 to 70 milligrams per deciliter, then I would say maybe I need to back off on the carb ratios. But here you can see that she has a much better time in range and also not a lot of hypoglycemia. So let's kind of pull this all together. On a very practical level, when you're looking at these CareLink reports, one of the first thing you look at is time in range, 70 to 180 milligrams per deciliter. As I had talked about earlier, you really want that target to be above 70. We also talked about sensor glucoses between 50 to 70 as well as less than 50. And I really try to avoid sensor glucose less than 50. So this is probably really one of the most important slides. And now that we actually have experience in patients using this in the commercial setting, we came up with these recommendations. And I had mentioned them a little bit earlier throughout this presentation. The first is the goal for time in range. So between 70 to 180, you really want to try to get that sensor glucose distribution above 70. In the case of the case study with Holly, she did quite well. She was in fact above 90%. And again, as we all know, we try to avoid hypoglycemia. What is that sort of target range that would red flag you? Certainly if you had a patient with 4% sensor glucose distribution between 50 to 70, that would be a red flag. You're really targeting for less than or equal to 3% between 50 to 70. I personally like patients down around 1 to 2%. And then, of course, less than 50, less than or equal to 1%, or really trying to avoid less than 50 altogether. For time in auto mode, above 80% of the time is a good benchmark based on our real world experience and also the pivotal trial, and also sensor wear time above 85% for patients wearing that sensor to really get the most out of the 670G system. So this is the second key slide, and there have been questions around what to do when a patient exercises, where there is in fact an option to use the temporary target. And that temporary target will raise the target goal of the algorithm from 120 milligrams per deciliter up to 150 milligrams per deciliter. So one could consider starting about 1 to 2 hours before the start of exercise using the temp target, and also to stop the temp target 1 to 2 hours after the patient has finished exercising. Now, if the patient has had kind of rigorous exercise for a prolonged period of time, you may want to consider extending that temporary target even beyond 1 to 2 hours. And in some cases, carbohydrate intake, in fact, may be required as well to avoid a hypoglycemic reaction. Let's say you have a marathon runner or someone who's hiking for 4 or 5 hours. Another option is that the patient still has the ability to suspend for at least part of their exercise period as well. So that's an option during exercise. So moving over to the second half of the slide, I kind of like to separate the forest from the trees, if you will. In regards to insulin delivery that the patient or the provider has control of, it really is only two settings: the active insulin time and the insulin carbohydrate ratio. When we're talking about the insulin carbohydrate ratio, you can look at the post-meal excursions. One of the reports that I like in CareLink is actually the post-meal overlay report, which we didn't have time to show, but is also available. And if the post-meal blood sugar is high, you can consider strengthening that carb ratio by 10%. And if the patient, you notice, is going low after they've given insulin for the meal, you can cut back on the insulin carbohydrate ratio by around 10%. Also, when you look at the response to a correction bolus, if the patient is still going high after a correction, one can consider shortening the active insulin time. So in the case of Holly, she went from an active insulin time from 2.5 hours down to 2 hours. And the recommended active insulin time is somewhere between 2 to 3 hours. I like to start with 3 hours and then adjust accordingly. If a patient is going too low after a correction, then it's recommended to lengthen the active insulin time. So let's say you're at 3 hours, you could go to 3.5 hours, or you could go to 4 hours or beyond. So we talked a lot about the auto mode settings. I wanted to move now to manual mode settings. So if you think about it, if a patient is in auto mode, and let's say they give a correction bolus, they're going to correct down to a blood sugar of 150 when they give that correction bolus. But what happens if they exit out of auto mode? What we're recommending right now is that the bolus wizard target is set very similar to what the auto mode targets are. So a bolus wizard target of 120 to 150 in manual mode. In order to calculate out what the basal rate should be used in manual mode, we're giving 3 separate recommendations. One is you could consider looking at the auto basal during auto mode and dividing that by 24 hours and just giving one rate. Or you could look at that one rate that you just calculated and then increase it for something like the dawn phenomenon, or just simply modify the current basal rate settings proportionally to what you have already calculated. Or you could look at the total amount of insulin given for the basal and then modify your current basal rates proportionally based on that total amount of insulin that is delivered by the basal in auto mode. And a very important point is that if the patient exits into manual mode and is having lows, to consider decreasing that basal rate by 10 to 15%.